This week on the BackTable Podcast.
And this dates back, like you said, in the 40s, 50s, 60s, when there weren't the antihypertensive options available that we have now. What was found back then, and there's some really cool figures of these really complex, debilitated patients with uncontrolled hypertension, and then they get surgical sympathectomy, and then their blood pressure drops precipitously, like 100 points. You know, what they learned from there is that that's an effective way to reduce blood pressure. It's overall safe. The kidneys can tolerate it if done appropriately, but it's morbid and potentially fatal, being that it's a high-risk surgery, you know, and in particular back in that period of time. You know, it's not surprising that fell quickly out of favor when we first started to get the contemporary pharmacologics that are available now. You know, these outside of back in the day where you just sedated patients to get their blood pressure down, all of a sudden you had calcium channel blockers, beta blockers, thiazides, diuretics, and then really there was no longer need for surgical treatment. But fast forward to the 2000s, I think it was easily recognized that we, even with lots of pharmacologic options available, still struggled to get people under control.
Hello, everyone. Welcome to another episode of BackTable Cardiology. I'm your host, Dr. Sameh Sayfo, interventional cardiologist from Baylor Scott & White, the Heart Hospital Plano in Dallas, Texas. Today, we have our guest, Dr. Eric Secemsky. Eric, thank you for joining us today.
Thank you, Sam. Appreciate being here.
Dr. Secemsky is an internationally recognized interventional cardiologist and vascular medicine specialist. He served as the Director of Vascular Intervention in the Cardiovascular Institution of Beth Israel Deaconess Medical Center in Boston. He also served as the section head of interventional cardiology and vascular research at the Richard and Susan Smith Center of Outcome Research and Cardiology, and he is an associate professor in medicine at Harvard Medical School. Many of you know Dr. Secemsky of his work in research in peripheral arterial disease and other vascular field. He is here today to discuss renal denervation, advancement, and innovation in the maybe one of the most exciting field of cardiology, which is advanced therapy of hypertension. So Eric, is going to be a fun episode.
Yeah, I'm looking forward to it, Sam. Thanks for having me.
Hypertension management for cardiologists, nephrologists, primary care physician, maybe it's the most common phone calls we get when we're on call. You're on call today, I think you're going to get a couple of calls of patient with high blood pressure, but it's not the only reason. I mean, hypertension is really very prevalent. It costs our taxpayers a lot of money. Many medication works or not work, a side effect. Recently, guidelines, both American College of Cardiology, AHA, came out with their guideline in 2025, and ESC came with their guideline in 2024, and they made renal denervation a 2B indication. Why do you think that happened?
Yeah, you know, stepping back, you know, I love your comment. You know, I think I've talked a lot about this in the last few years about being in cardiology clinic and you have your problem list, and everybody in cardiology clinic has hypertension, but, you know, usually that's number 5 or 6 or 7 on your list of problems. So here with chest pain or AFib or heart failure, and then the hypertension kind of gets missed. And so, you know, we've kind of been on this idea that we need to flip that problem list upside down a little bit and make sure that we're focusing as much on the contributors to all these other medical problems as we are with just the end stage medical problem. And so, you know, I think the updated 2025 hypertension guidelines were very welcomed. We needed a refresher. We needed to be reminded on getting aggressive early on in hypertension management, whether that's with, you know, going straight to 2 pills for certain stages of hypertension, lowering the blood pressure threshold for patients, and then also thinking a little bit about risk and the PREVENT score in terms of titrating really our blood pressure goals and therapy. So, you know, it was a great update, but probably the most exciting thing, back to your question, Sam, that, you know, all of us, in particular in the interventional space, were watching was renal denervation. And as you know, the guidelines are updated, not with any correlation with when new therapies are coming to market or whatnot. But, you know, so it's great that we've got renal denervation in the guidelines, but it also came pretty early in our renal denervation experience. So to your point, you know, right now the ACC-HA guidelines give a class 2B recommendation to renal denervation, and for specific patient population who are on multiple medications or made uncontrolled. And, you know, this really aligns with where most of the clinical trial data came from. You know, again, the clinical trials sometimes are funny enough designed to satisfy the regulatory bodies, and then we use the guidelines to try to capture the evidence into clinical practice. Yet we use renal denervation maybe slightly different than what the guidelines recommend. But nonetheless, I think the 2B rating both gives a vote of confidence that renal denervation has a role in 2026 for managing difficult to control hypertension, but also recognizes that we still have some growth in this field to generate more data, in particular for looking at other populations at high risk that could benefit from this therapy, further randomized trials that are ongoing, trying to get a little bit more harder long-term clinical event data. Do we reduce stroke, MI, heart failure with renal denervation? It's a hard question to answer, but also is a necessary one. And so, I think this is where we start. I think we're happy to have a recommendation, and I think we've got a lot of room to grow this therapy and feed it really into a lot of exciting stuff that's happening in hypertension, even on the pharmacologic side.
It was very exciting to see that, it's rarely that ESC and, AHA guidelines comes matching. And it was very interesting to have both pointing out how important that technology is. But stepping back, reading, it's a very nice read. I really recommend all the audience to read it. It may be a little bit dry for interventionists, but it really point out the importance of understanding the simplest thing about hypertension, even agreeing on how do you do ambulatory pressure monitoring, how you do home monitoring, even clinic. Do you think has that guideline changed some of the practices you do on a day-to-day basis, just from a simple hypertension measures or medication management?
Yeah, I think that's a great comment, that there are some best practices in there that we have to remind ourselves that often get missed, and even the basics of like, what's the appropriate way to check your blood pressure? We have so many home monitors now for patients, but rarely do they get instruction. What's an approved or validated home monitor versus ones that may not be approved? There's a lot of attention on the toughless blood pressures and some of these new technology that haven't really shown the strongest of correlation with office blood pressure or medical grade devices. And so, like you said, it's definitely for anybody in this space, interested in this space, whatever your specialty might be, that you have to be comfortable with the full gambit of how do we measure this accurately? How do we guide our patients? And then, like you said, how do we introduce therapies based on blood pressure and risk goals? And so those are all critically important and nicely covered in this document. And like you said, you don't see that in one place very often.
You and I are not old enough to remember the surgical sympathectomy, but that's when I would say the beginning of understanding that sympathetic nerve play a role in hypertension. And that was in its 60s when they do surgical. But we both were in training or early career when the early renal denervation started with Symplicity trials. Can you walk the audience of your experience or an understanding of the early stage of those trials? Why did it not work? Or maybe some of them worked and the other didn't. And why do you think there were like almost a 10 years of standing still in this technology?
Yeah, it's a great question. The field really is on the backbone of, like you said, the surgical sympathectomy. And this dates back, like you said, in the 40s, 50s, 60s, when there weren't the antihypertensive options available that we have now. And what was found back then, and there's some really cool figures of these really complex, debilitated, patients with uncontrolled hypertension, and then they get surgical sympathectomy, and then their blood pressure drops precipitously, like 100 points. What they learned from there is that that's an effective way to reduce blood pressure. It's overall safe. The kidneys can tolerate it if done appropriately, but it's morbid and potentially fatal, being that it's a high-risk surgery, and in particular back in that period of time. So, it's not surprising that fell quickly out of favor when we first started to get the contemporary pharmacologics that are available now. These, outside of back in the day where you just sedated patients to get their blood pressure down, all of a sudden you had calcium channel blockers, beta blockers, thiazides, diuretics, and then really there was no longer need for surgical treatment. But, fast forward to the 2000s, I think it was easily recognized that we, even with lots of pharmacologic options available, still struggled to get people under control. People have a hard time taking their meds. They have a hard time taking multiple meds. They have a hard time taking multiple meds that they have to take multiple times a day. And they have a hard time taking multiple meds multiple times a day when they have a whole bunch of other meds to take and they get side effects. And so there needed to be some sort of investigation into an alternative treatment option that did not require the adherence on the patient on a daily standpoint, that maybe could make medical therapy easier. And that's really where going back to sympathectomy was on top of people's minds. And this, again, was really supported by the fact that although, when you surgically remove nerves, you're doing it at a much more proximal and part of the sympathetic chain, that in the focus of catheter-based denervation, that the nerve endings sit really closely to the vessel lumen, and particularly further down in the renal arteries. And so you have these deeply innervated renal arteries with nerve endings sitting close to the lumen. And also you have both the afferent and efferent nerves that run in parallel together. So you have to really be able to treat both of those to be effective. So now you've got really great anatomy set up for moving forward with the catheter-based intervention, but how do you actually ablate the nerve safely? And that's where the secret sauce really came about, was you do this with different energy mechanisms, but the primary one is really thermal ablation. You can generate the right amount of heat to damage the nerves to the point that they will fibrose and not grow back, but also without damaging the arterial wall, that you now are left with a poorly functioning kidney or renal artery stenosis. And so that was really, I think, the magic behind catheter-based denervation. Now, you moved into the troubling period of this. So we've got some great proof of concept in the 2000s that a minimally invasive procedure with a ablation catheter, which we were getting familiar with in the EP side and elsewhere, can be effective here, but we needed to prove it in a clinical trial. And the early clinical trials, the early Symplicity studies, showed really remarkable benefits with catheter-based renal denervation for hypertension. We're talking like 15, 20-point blood pressure reductions at 3 and 6 months. And everybody then got into this space. Everybody had a catheter. Everybody was acquiring a catheter. This was, all that was spoken about until the decision was made to randomize patients to a sham procedure. And that was Symplicity Hypertension 3 in the mid-2010s. And the challenges there were no one had done a true sham procedure trial in this realm before, and it proved to be much more difficult than you would have imagined. If you look at the trial data, we call this a unsuccessful trial. And it wasn't that renal denervation didn't lower blood pressure. It was that the sham arm lowered blood pressure just as much. And now in theory, a sham arm shouldn't lower blood pressure 10 points. So something else must have been going on. And so that really was the unmonitoring of people taking breakthrough medications. You get randomized in a trial, you're hypertensive still, but you didn't get renal denervation. You show up at your primary care doctor who had no idea you were in this trial and said, well, why are you not taking more meds? Or you go home and you start taking your meds because you're scared because you're seeing these numbers. So there's a lot of breakthrough medication use in that trial that really challenged the interpretation. The other part of it, though, also was a little bit on the design. Now, again, this was a Medtronic's device. And in the first stage of that device, it was just a catheter with an end-hole electrode. And it became a little bit obvious that there was irregularity and heterogeneity in terms of how the artery is being ablated. And really, you need to be consistent with your ablations to make this effective. And so the redesign of the catheter is a Spyral, and I always say it's dummy proof. You move the wire back, it deploys and it ablates, and that really allowed the ablations to be controlled for in terms of consistency and location. And also, Recor's device, which is a balloon-based thermal ablation catheter using ultrasound-based technology, also has a very easy, predictable circumferential ablation. And so I think that was a big part of it. And the only one that I'll say also that we learned from the Hypertension 3 exploration was, the nerves deeper in the branches tend to be most consistent in people. We've seen some more anatomical variation if you only ablate the very proximal artery. But if you get to the mid and distal artery, we start seeing much more consistent nerve wrapping around the artery. And that really became the key target for where to ablate. So we learned 3 things. Control your sham arm. Make sure that as long as it's safe, that they're not taking medications. Make the device dummy proof so that there is consistency in how it ablates. And really focus as much as you can in the mid-distal artery and beyond, because that's where there's most consistent nerves across patients. And I think that's how we got from a failed trial to now more than 6 successful trials and led to the FDA approval of 2 devices in the U.S.
I love the way you look at it. I think many people, I remember I was in the audience when they presented it, in the 6 panelists. All of them were like, nah, maybe there's something wrong with the study because we believe in the technology. I remember that very clearly. But we learned from it, as you mentioned, and many studies are happening based to understand how we're going to monitor this, because if patient taking medication or extra medication. So let's go. You mentioned 2 devices. There's a 3rd and 4th and 5th. I think there's going to be a lot of those devices. Can we go over one by one? The field of renal denervation now is being led by 2 companies, maybe in the future going to be 3 or 4, The one that we have commercially available is the Spyral from Medtronic and the Recor or Paradise from Recor. Let's start with the Medtronic device. Can you talk to the audience from a technical perspective? How does the procedure be done? What's your recommendation, guide size, things like that?
Great. Yeah. So the first platform to mention is Medtronic's Symplicity Spyral catheter. And again, so this is kind of their second gen catheter because, as I just mentioned, it moved from a end hole, kind of an end ablation catheter to this spiral with 4 electrodes on there. So it's a device that I've used a lot. It's commercially available outside the U.S. as well, both the older version and this new one. So the nice thing for their program is there's a lot of data on this device and safety in particular outside the U.S. as it's been approved there for a number of years now. The device is a single, as we say, single SKU device. So there's only one device. There's no different sizing or whatnot. And it fits all arteries between 3 and 8 millimeters. And that's really important because the other thing that we discovered in early clinical trials is accessory arteries, which can be up to 20 or 30% of the population, are also richly innervated. And so if you don't treat the accessory artery, you could potentially also blunt your blood pressure response. And so anything that's a 3 millimeter accessory artery or greater, we treat along with the main arteries. And again, there's quite a few patients out there who have at least one or more accessory arteries. Now, the Symplicity Spiral catheter goes through a 6 French sheath and a 6 French coronary guide. So we use a shorter guide, a 55 centimeter guide, but it's the same guide and same guide size as you would use for a normal coronary guide. And obviously, all the different shapes are available also in the shorter guide. It works on an 014 platform. And right now, it's really meant for femoral access, though for all the companies, there's interest in getting into radial access as well. And I'm sure we'll hear more about that either later this year or next year. But right now, this is a femoral access procedure, 6 French sheath, 014 wire. Now, the nice thing about this device is you put it in the artery, you pull back the wire, it takes its form, and then they have a smart generator. And that generator is going to tell you that you're in good position for the electrodes, that you're going to make good contact, and it has safety feedback. So if you are making the artery too hot, so let's just say it spasms, and the energy profile is too high that it could actually damage the vessel, it'll turn off that electrode. It'll leave the other ones on because there's 4 firing at once, but it'll turn off the one that might be getting that feedback, or if there's more than one, it'll turn off more than one. On the other hand, if you are making poor contact, the patient moves, you're in a larger vessel than you expected, you're at a branch point, it'll also tell you that you're not making good enough apposition of that electrode to really give a treatment that is successful. And so it will also give you an error message. So it's very smart, and it also gives you the opportunity to feel comfortable that, that vessel is like 2.95 millimeters. Should I treat it or not? Well, I put it in the catheter, and if it gets good thermal energy, good feedback, and it's safe, I'm going to treat it. And the system will tell me if it's not safe to do. And so that's been a real plus. So one device for the whole procedure. You can use it on both sides. There's no limit to amount of ablations on it. And the biggest challenge with the Medtronic platform is it's really meant to be denervating distal in the branches. So the ask for the procedure is that anything that's 3 millimeters or bigger outside the parenchyma of the kidney that you try to treat. So we're very exhausted with the ablations. The ablations are about a minute long, but there's 4 firing at once. And so you just have to be a little bit more technically invested in wiring the different branches, and they could be a little tortuous and whatnot. But I'll tell you, with my experience, I've done more than 40 of these cases now. The learning curve is quite steep, and as I've done more, my procedure time ends up being lower and lower, and I kind of know what to go for and how the catheter works to my advantage. So that's the Medtronic device. I get this question also a lot. There's no need. In the trials, they put people on aspirin for a month or so after the procedure. We don't do that in clinical practice. We also don't really do any surveillance imaging for renal artery stenosis because the frequency was so low in all the trials. So people go home the same day. Usually it takes me about 45 minutes to do the ablations, an hour to do the procedure. So it's a quick recovery time, and everybody we've treated has gone home. And so it's been really easy on the patient, and the procedure's gotten really easy as we've gotten comfortable with it.
So Eric, before we move to the other technology, can we talk about troubleshooting for this device? So if someone keep getting alarms or saying either the contact is not good or the impedance is changing really rapidly, or maybe the heat is too much, what are the few things to prevent patient from movement, maybe adjusting the device? What are the tips and tricks that you recommend?
Yeah, great question. So again, you really usually get 2 alarms. One is too hot, one is not hot enough. Too hot, usually that can be spasm, so we'll give nitroglycerin. We keep a lot of nitro on the table just to make sure that we've got good, dilation of the vessel and make sure we understand the size and it can accommodate the catheter. And then also, we think about the sizing a lot, just making sure that we're staying within that 3 and greater millimeter sizing. On the not hot enough side, sedation is a big part. And so again, it's a minute ablation. I find that the distal branches tend to not be as uncomfortable for the patient, but the more proximal ones can be a little bit more uncomfortable. So you just have to get comfortable about how to best use your sedation. And this topic comes up a lot is, do I need general anesthesia for this? What's the right way to do the sedation? Again, we've done 40 more cases, all with just conscious sedation in the cath lab. We've used IV Benadryl to kind of augment some of the sedative powers of the fentanyl Versed cocktail. I've heard the other day someone was telling me they were using IV Tylenol for some additional pain control. But most of the times, as long as you plan out how you use your sedation, you can get people pretty comfortable. So that solves that one. The only other time that we make adjustments to the catheter because of not enough heat is sometimes you need to kind of reposition the electrode. So we might take a little turn on the catheter and tighten up the pigtail a little bit, and that will give us better apposition of the electrode and usually solve our problem. So, we inevitably get a few error messages during the procedure, but very rarely is it not anything that is easily addressed, and we usually kind of know it going into it that we may not get all of the 4 electrodes to fire, and that's when, again, we will make some adjustments. So, you get used to it and you know how to respond pretty quickly.
A couple of the tips about the sedation, we start using IV Presidex, but you need to make sure that your anesthesiology department sign you off on it. Just there's some regulation there. And for anybody who's using IV Tylenol, I really recommend them to go to the pharmacy and figure out how much it costs, because usually they're very expensive. We use them for cabbage and it's a very expensive drug. So unless you have a good deal with it. So Spyral works great. This data looks great. We've had multiple data for Spyral. There's ongoing registry. I think we covered it very nicely. A lot of people say, well, what is this Paradise device? What's the difference between Paradise and Spyral? Can you walk us through, very similar to how we covered the first one, what is Paradise device?
So Recor is a company that really has pioneered the ultrasound-based renal denervation. And so the same properties at the nerve level that it's being ablated by heat is preserved between the two. And I didn't make a comment, but the Medtronic Spyral catheter uses radiofrequency ablation, which we've all been very exposed to throughout our careers. In particular, that was really the original energy source in cardiac ablation. But Recor, developed a newer platform that relies on ultrasound-based thermal energy. And so pretty much they have an ultrasound probe that sits in the middle of a balloon catheter. The balloon accommodates saline that is then heated by the energy generated by that ultrasound probe, and it's communicated to the vessel wall. And then cooling comes into that saline, so the saline is heated and then it's cooled. And that's supposed to preserve the safety of this again, and that the vessel wall is exposed to that heat, but it's a 7-second ablation. It's temporary, and then it's cooled by the return of saline in that same balloon. And so really cool technology. And I think the nice part about this is interventional cardiologists in particular, any endovascular specialist, balloon-based therapies is the cornerstone of our devices. And so it's a very intuitive platform for us to use. The properties of the device itself are pretty similar to the Medtronic, just a couple differences. One is that it's a 7 French sheath and 7 French guide. So it's just a one size up. Probably doesn't matter too much for the average person. And then it's still an 014-based wire platform, but the balloon is really meant to serve the proximal vessel. So, anywhere in that main branch. So still get those important nerves I talked about that tend to start coming in the distal main branch, but it really is focusing its treatment there. And the pros there are it's an easier location. You don't have to go back down into the branches with your wire. The ablation time is 7 seconds. Things to keep in mind is the balloon only works. It's kind of like any specialty balloon, whether intravascular lithotripsy or whatnot, only works if you're really opposed to the vessel wall. So you have to be really well-sized with this platform. The balloons come in different sizes so that you might have a step down in the vessel caliber where you might use a smaller balloon for one area and a bigger balloon for the other area. But you just want to be really well sized for this. The only other challenge also is right now it's not indicated if you have a renal stent in place. So because you do rely on that proximal artery for the catheter, you have to really avoid people who've had renal stents. The Medtronic device you can do distal to the renal stent. They just have to be 90 days or more outside of when they got the renal stent. So that would be the only challenge on the anatomy side. But again, very easy platform, quick ablation, 7 seconds. And I think it's near and dear to our heart as balloons are easily understood. And so I think really a great complementary tool for renal denervation.
I think you mentioned something very crucial. I think it's very important to make sure that you're opposed to the wall, and that's why they recommend when you have the inflation to take a gentle puff and make sure there's no contrast going through. But people are concerned if when you have an ultrasonic energy, is there any risk to injure a neighboring vessel, veins, artery? Has there been any study to look at that?
Yeah, really great comment. I think, the one thing that you'll hear a lot about with radiofrequency ablation is the blast zone, so the amount of thermal energy generated, is not as deep as maybe ultrasound is, and that's in some ways by design. But the nice thing about thermal ablation from radiofrequency as well is that the temperature is really controlled so that it heats the fat around the artery. The fat around the artery is where all the nerves sit. So you just want to boil the fat so it boils the nerve endings, but you don't want to damage the lymph node and the veins and whatnot next to there. And so that's where you can avoid any off-target damage. For the Recor device, it's got a larger blast zone, if you may. And again, it's treating more proximally, but I think also the structures around there are a little bit more spaced out. And we never saw any clinical data to suggest any harm to surrounding structures. And I think that's really important. I used to get a lot of phone calls early in the RDN world where people, especially outside the US who can't get access to these, would be like, why don't I just use one of those EP catheters and ablate the ganglion? And like, why are we worrying about all these distal nerves? And the challenge there is that there's other off-target structures to get their sympathetic innervation from the ganglion. So, we want to make this a really safe procedure for our patients. It's novel, it's new, it's elective. And so, I think being really targeted with the nerve endings was the right approach and not trying to be more proximal right now in the ganglion. So, yes, I think that, I know that there's been a lot of benchtop testing, translational testing, early animal testing, and then human testing for the Recor Paradise catheter. And then as far as I've been educated, there's never been a real sequela that's of concern based on where they're treating proximally and with a little bit more of a depth zone than radiofrequency.
So just to emphasize to the audience, when we say more proximal means not into the branches, but you still try to get it throughout the whole main artery, correct?
Yeah, everybody's anatomy is different, and even from left to right or right to left is different on each person. So in theory, it makes, the most common presented anatomy we see is just a long main renal artery with branching that happens in the mid-distal portion or beyond. But we also see a lot of people who have branching early on and some variation. But that's completely right. We want to focus really on that main artery with this technology, but the whole extent of it. And again, it goes back to my earlier point that everybody's nerves might come in at different locations off the ganglion, and we just want to make sure we're covering all our bases when we ablate. So, Recor's done a really nice job. Again, same diameters, 3 to 8 millimeters they can cover with their balloons and allow that ablation to be in the main artery, but throughout it.
From a practical perspective, how do you decide which balloon to use? Are you IVUSing? Are you doing QCA? Or just guessing and then put the balloon and you take a puff? Because in the procedure, you can use as many as balloon as you want. It's one per procedure, right? It's paid per procedure. How do you decide that?
Yeah, I think there's a couple different approaches that I've seen. CT imaging has been a really reliable way to size. So in some of the trials, that was part of the enrollment criteria was a CT scan, and particularly to look at sizing, but also helps with things like looking for renal artery stenosis and whatnot. And then I've seen also an uptick in IVUS use at the time of the procedure to size. And so again, Sam and I, we both share our passion for IVUS, and I think that this is a great tool if you're unsure about the sizing based on the CTA. You could also use QCA or the equivalent of that for measuring based off the angiogram, in particular if we use DSA for your imaging. But, if you're ever uncertain, IVUS is the right way to go. But you also mentioned the confirmatory test, which is you put the balloon up and you shoot that contrast and if there's no leak around the vessel or around the balloon into the distal vessel that you've got the right size. I think that's also an extra layer of support that you're sized appropriately.
And also for the audience, the company will provide you with basically a table. If you estimate anything, just tell you the right size of balloon you need to use based on the vessel. So it's not one-to-one. Sometimes you have to go a little bit of a bigger balloon because it's a lower pressure device. Can you comment a little bit before we move on? What is in the pipeline? What's the innovation that's making you excited by this? What's happening? Who's else getting into this field? And what are the products that you're aware of, that you're part of, that make you excited?
Yeah, I love that question. So just to round out, I think right now we talked a little bit about radiofrequency ablation. We talked about ultrasound-based ablation. There's a newer player that was acquired by Boston Scientific called Sonovi, which is also an ultrasound-based platform, but it's not balloon-based. So it's an IVUS probe almost that delivers thermal energy by centering itself in the vessel and then creating that energy platform. And they've got a pretty deep amount of penetration that can go with that device. That one was acquired, but prior to FDA approval. So the Thrive study, which is their off-med randomized trial, is ongoing right now, and the device now sits with Boston Scientific. So hopefully next year we see that in our hands. I don't know if that's optimistic timing or not, but it would be great in the near future to have another device available. And then there's a whole other class of renal denervation that we didn't cover, which is using neurolytics, and so alcohol has been one that has been trialed in several different platforms. Probably the most familiar is Ablative Solutions has a balloon that delivers alcohol into the perivascular tissue, and that can destroy the nerve endings. And they had some really great data. They're back running their final trial again, their off-med trial, and that will really kind of dictate next steps for that company. But I think that there are some early data that really suggests this can be a capital-free, so maybe a little bit more affordable and also less pain approach. But we got to see that out of this trial and into the next phase of that device's future. In terms of other needs, though, the kind of pressing questions are, we see people who respond so robustly, and then sometimes we don't see that same response for the next person, and it's really hard to understand why. And there might be a lot of different areas that could be affecting that. It might be something at the patient level. It could be, stuff like uncontrolled obstructive sleep apnea, obesity, yada, yada, fluid retention. But also, there is that question of, are we leaving nerves behind? We do as much ablation as we can, but we don't know where the nerves are, and we don't have a confirmatory test to tell us how the nerves are ablated. And so kind of in investigation right now, there's a company in China that has a mapping platform where it will actually map out the nerves, and even to the point that it'll tell you which ones are hot or really active in driving blood pressure and those who are not. So whether we need to be mapping the nerve plexus and then treating a little bit more strategically is one approach. The other one also is just a confirmatory test at the end of the ablation. You do your full thing, you think you're done, and then you kind of evaluate whether all the nerves are shut down after you've finished what you think is your complete ablation. If you still see nerve activity, then maybe you go back and treat more. And so I think that's really what's going to help us get to the next level in this field. I mean, again, I'm sure the EP docs are looking at us interventionalists messing around with their ablation catheters and saying they don't even know what they're doing and they're working blind as usual. So there will be some progress there. The last thing I'll just comment on is the concept of multi-organ denervation. So again, we just got introduced to renal denervation. All of a sudden we've moved on to the next thing. But there's been some data around for some time that said the hepatic artery is richly innervated with sympathetic nerves. And there might be some synergy or some communication between the liver, the hepatic artery, and the kidney for driving blood pressure, as well as some metabolic benefits of overactivity or underactivity of sympathetic nerves. So we've seen some early data. We saw something called the Nectar-4 trial at TCT that Ajay Kirtani presented that showed that if you do a common hepatic artery denervation with renal artery denervation, you can potentially get a more augmented or predictable blood pressure response On top of that, though, they saw that the A1C dropped for people who are diabetic and dropped pretty remarkably, in some patients up to a point or beyond, and some other people half a point. But still, it's almost like a GLP-1 agonist by a device. You could potentially use that to be treating some of the metabolic issues that also are very concomitantly present with uncontrolled hypertension, and also maybe benefiting the hypertension profile or response. And so Medtronic has a trial right now called the Spyral Gemini pilot trial, which is doing a common hepatic artery denervation with renal denervation. And there are other companies that have looked into this as well, as I mentioned, that really I think will push us thinking more broadly about where this technology works, and maybe also showing us some bigger numbers on blood pressure drop that I think we'd all be interested in seeing.
I think that's why many of us are very excited about this field, because I think it's the beginning. The two companies who have commercially available devices are paving the way, but we just started, and it's good to have positive data. You were part of the writing committee for the SKY position on the renal denervation, and SKY has made some recommendation, and actually, ACCHA kind of had similar recommendation in terms of building renal denervation program. Can you go over just maybe the summary of what SKY has offered us in recommendation wise to make sure that we're doing this not only effectively but safely?
Yeah, that was a great document. Again, really kudos to SKY. They've been at the forefront of really helping us bring renal denervation to commercialization, because there's a lot of work that was being done, and I was fortunate to be brought into this before RDN was approved. And it was just like simple stuff of like, who's going to triage these patients, who's going to follow them up, who are the right patients for this procedure, what do you need to have at an institution, what do you need to have as an operator to feel comfortable with this procedure. The good news is it's not a very hard procedure, and I think that for some people, that's a great thing. Some people say, oh, well, I'm going back to dual access CTOs for 6 hours and you can do this, Eric. But I think that it's a very readily accessible procedure. And I think people early in their career can get comfortable with this. People late in their career can get comfortable with this, or anything in between. In the SKY document, we really set up a couple, premises for bringing this technology to clinical practice. One is, really this is best embedded when you have some support on the hypertension management side. And as you get further into this, you realize that there's a lot of patients who are referred for renal denervation, but probably just needed some optimization of their meds, some encouragement to take their meds. Some people have secondary causes that weren't fully evaluated, and we see hyperaldosteronism is as high as 20% of cause of uncontrolled hypertension. And so, really having a good program not only serves our patients better, even if they're not getting renal denervation, but make sure that we're selecting the right patients for this procedure, and an embeds area to be able to follow patients even after the procedure. So, for instance, in my program, my partner Anna Krawis and Jennifer Cluett have a complex hypertension program. They do the workup, the screening. They send me the patients. I might meet them the day of the procedure, or I'll call them on the phone, make sure they don't have questions, do the procedure, and then they follow back up in the clinic. And that's worked really well for us. So the cornerstone of this is just it doesn't have to be a big hypertension center. It doesn't have to be, a unique hypertension specialist. It's more of just a dedicated practitioner who wants to manage the hypertension side, because I think it's hard for us to do as interventional cardiologists when we're not in the clinic with that same frequency as some others. Then, really it's the facility. That one's easy. There's not really a lot of special imaging that's needed here. I tend to use digital subtraction angiography when I do my renal denervation, at least the abdominal aortogram. But outside of that, it's normal cath lab equipment, normal cath lab techniques. So that one's pretty easy. From the procedural operator side, this was a big debate, was how much experience do you need to have cannulating renal arteries to be able to do this? And like me and you, Sam, like we've, trained in vascular. We have probably, done more renal stents than most people in this space. And so that was a pretty natural place for me to be, doing procedures. But for people who are just not trained in vascular, like you probably haven't done a renal angiogram maybe ever in your career, in particular the last 10 years where we really haven't been doing as much renal stents. So, the goal there was to create some goal for the operator to get some experience with endovascular procedures, and particularly with just engaging renal arteries if they don't have endovascular privileges, but not make it prohibitive like you have to go back and do a fellowship. So, we ask that our operators do around 10 renal angiograms, but they can be supervised. They could be adjunctive with a partner. The device companies typically want you to do 5 proctored renal denervation cases before you're signed off, and those can contribute to that number. And so trying to create a number that was accessible and not too much hurdle for the average operator, but also allow people to get comfortable. And, last thing I'll say is the complication rate in our experience has been very low, but there's never a procedure that's 0 complications. And if you're going to have a complication, it's either the guide's going to dissect or you're going to have a perforation distally. So you just have to make sure if you're not comfortable with coils or glue, or if you're not comfortable with a renal stent, that you have a colleague, whether it's IR, vascular surgery, another cardiologist, who can support you if that happens. Again, having seen the data, doing these procedures, that is not a frequent occurrence. And I would say it should not be a frequent occurrence if you're doing this right. But there are things that just inevitably happen and you have to be prepared for.
I think the debate about the renal angiogram and the renal intervention has been really hot topics even inside institutions, because if you open it up and then you get one complication, it may kill your program. The emphasize also on, I think document also emphasized on the true definition of resistant hypertension, which is extremely important. This may become a first-line therapy in 10 years when we show the safety and efficacy, but for now, it's only for resistant hypertension. So I think that was very nicely put on the paper. I think that's also one of the papers that I think if you're building an RDN program, it's really worth an important document to have. Do you think, from your experience, what would be the incentive for institution to create an advanced hypertension center or clinic? Do you think, from your experience and other people that you've talked to, is it easy to happen, or are they seeing a lot of pushback there?
Yeah, great question. I think it's been really a gift to our institution to have one. We had doctors in nephrology, endocrine, and primary care doing hypertension management here, but we weren't ready, I think, as an institution for a new therapy like renal denervation. And so before approval, I kind of saw this coming, and I reached out. We had a graduating fellow, this Anna Krawitz, who trained with us in vascular medicine and cardiology. And I approached her. I said, maybe hypertension would be an interest of yours. And she said, let me go explore. And she spent some time with a hypertension specialist. And he came back and she's like, I love this. Like, this is what I want to do. And so then I went to my boss, our chief of cardiology. I said, I want to put a hypertension program in cardiology, and I think it will benefit us. I already have lined up our faculty member. I don't think we're going to need a ton of resources to start. And I think also if renal denervation gets approved, we can fold this in really nicely. And I got immediate buy-in. You know what? No one is doing that in the cardiology division. It's a great opportunity for our faculty member, and we can, support that. And, now fast forward, we did that, 3 or 4 years ago. It's a huge flagship program for our center. We have patients booked from all over the New England area coming to see us. They're booked out. Our program is full. We have fellows who want to spend time there and want to learn more about hypertension. We have a dedicated advanced hypertension and vascular fellow. We have more faculty coming into the center. So even in a short amount of time, it's paid back. And it's not, again, only paid back because we're doing thousands of renal denervation. We're not doing that, but we're taking care of patients who've been falling through the cracks. We're giving really good care. I think that it's well recognized throughout the system that it's unique. We still don't have a lot of these centers across the country. And so, I think you knock off a lot of really important metrics when you build these out. And again, they don't have to be these big, sophisticated centers to start. Maybe they become that over time. Maybe they don't. But it's more just that you have dedicated practitioners taking care of a very prevalent disorder. And, we have lipidologists and preventative cardiology doing this for cholesterol. We have this for diabetes. This has just become important in our field for these primary risk factors because we don't have the bandwidth as the average busy nephrologist or cardiologist or even endocrinologist to expertly manage hypertension in a 15-minute follow-up visit.
It's phenomenal that I think every time I talk to someone who has built this program, it's a very replicated story. We had the same experience. We started 3 years ago. Dr. Mubashir Khan and Dr. Mark Metzinger kind of started this, they championed it. And I think what you just said there is important. You need to have a champion. I think for any of the program, if you just want to do it, and someone who does vascular medicine or interventional or nephrology and then doing it on the side, it usually doesn't work very well because it requires a lot of time to build it. But definitely also it's important. I think there's a certification for the centers. It's important to have. Physician can be certified as an advanced hypertension clinician. I think that's also important. But what we've noticed from our institution's success is there's a halo effect that we do not think about till we start doing this. And also, as you mentioned before, those hypertension patients, if you don't have them controlled, they come with stroke, they come with heart failure, they have admissions. So that has been minimized in our institution. And I think it's exciting. It would be great to have, and I don't know if you're aware of it, I know you always have insight of things that nobody else has. So it would be great to have a way to have a database for those centers that maybe there's a handful across the country, and see if there's any data to support this kind of initiative. Do you know any database being built in the recent future similar to NCDR or TVT and things like that?
Yeah. So very salient question. So thank you, Sam. I don't know if that was underhand served up for me or not, but we that was, I mean, again, we're always so aligned. And so when we were launching Renal Denervation, one of our immediate thoughts was like, we need to track these procedures. We need to make sure we're doing them in the right populations, doing it safely, and also ideally have the data on hand to feed back to our referring docs to make sure that they see that their patients are getting good care and this novel procedure is working. And so we started internally building a registry. We inquired a little bit to the AHA and other societies, ACC and whatnot, if there was any plan for a registry, and there wasn't at the time. And so we started just reaching out and try to broadcast as broadly as we can a registry. And so we ended up starting just here up at Israel, and then we got some great partners, Cara East, also in Texas, the Penn Group with Ty and Jay and Debbie Cohn, Colombian, Ajay Kirtani, and all of a sudden we had a multi-center national registry. And so we have this registry that's been built. We have about 20 plus centers participating, and then as of right now, the plan is for this to actually fold into the NCDR CAF PCI module. So in the future or more, we had an announcement last year that this will become kind of one of the NCDR suite of registries that you can track your renal denervation procedures and outcomes. And we can make sure that, again, we're doing the right patients, that we can feed that data back to our referrers, and that we could do research on this as well. And so we have more than 100 plus procedures in the registry that we've run, but that will, again, be magnified when it does move to the NCDR, the American College of Cardiology. And then, again, we've also explored, and, again, anybody listening to this, hopefully you already have Sam's contact and mine as well, but explore doing something more just on complex hypertension and some of the other attributes of care that go into, resistant hypertension also. So we've got some great initiatives there, but there definitely was a need for a registry. I hope this continues the momentum that we've kind of seen already to grow, and I think it will lead to a lot of great academic opportunities, as well as just making sure quality-wise we're doing the right thing for our patients.
Always a pleasure to talk to you. I think we can talk for a couple of more hours, but I know you're on call for today. Thank you so much for taking time of your busy schedule to be with us today, to share with us your insight and your expertise. And thank you for all the work you're doing and all the colleagues doing in renal denervation. Looking forward to seeing you in a future podcast.
Thank you, Sam. And thank you, BackTable. I appreciate it.
Thank you so much for joining us on BackTable Cardiology.
If you have not already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend.
If you have any questions or comments, direct message us at _BackTableCards
on Instagram, LinkedIn, X, TikTok, Blue Sky, or YouTube.
BackTable is hosted by Hadi Lisha
and Sameh Sayfo.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe Legrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for tuning in.
We'll see you next time.